Our last conference, I gave Melissa an impossible task. I think I gave her about a 45-minute time slot to tell us everything in the world about gut health. She did an amazing job. It was like speed dating of gut health. And she did really well. So we want to make sure she's got slightly more than 45 minutes to discuss a really important topic that's a hot topic, an emerging field of knowledge, and that is post-frenotomy care. We're seeing huge numbers of tongue-tied infants in our bodywork practices, and certainly lactation consultants are seeing huge numbers of these babies too, or a huge proportion of the babies that we are all seeing in these related professions. And many of those babies are having frenotomies. They're having procedures to clip or laser the redundant frenulum, and we're trying to figure out then what. How do we care? How to best care for these babies afterwards? And so I'm so glad that you're here. Melissa is one of our most amazing and most talented lactation consultants in town. But even if she lived on the other side of the country, then I would say she's one of the most amazing and talented lactation consultants in the entire continent. And it's really true. So welcome, Melissa.
Thank you for having me, Carol. Thank you. It's an honor to be here. I'm curious how many of you, with a show of hands, do work with babies post-frenotomy? Okay, wow, that's great. That makes me happy because that means a lot of babies are getting referred for body work, so that is awesome. I am going to talk just a little bit about pre-care, but this is not going to be a talk on assessment or anything. It's really going to focus on the aftercare. But I do want to just dedicate this to the babies and moms I work with because they really go through hell and back often just to feed their babies, and they are awesome. Okay, so some objectives that we're going to go through are describing some anticipatory guidance for these families, understanding some key issues, and identifying and targeting care afterwards. All right. I think until recently, in the last maybe few years, frenotomy was pretty much thought as a clip it and forget it type of a procedure. Just, do it, take care of it, and everything will be fine. Some new thoughts around this have been emerging. And I think that it's still in its infancy. So my talk, I certainly don't consider to be the be-all, end-all. It's really a work in process that all of us will be adding to the body of knowledge around. Okay. So for this audience, I just want to have a baseline of how my practice has shifted over the last few years. So I used to be maybe the one identifying that, hey, this is an issue, seeing a baby pre-frenotomy, during treatment, and then afterwards. So I really could see what's their baseline of functioning, what is a compensatory behavior prior, what are they doing after. There's been a dynamic shift in my practice, and it may be where some of you are at. Now I feel like the cleanup crew. So I'm seeing mostly babies after treatment. They've been treated somewhere, and then I'm seeing them, and I have no baseline of often how they're functioning, how it was prior. I'm just seeing what they can do afterwards. So I just preface this talk with that. This isn't going to be a talk about how to do craniosacral on babies post-op, like follow your heart, your hands. You guys are all the experts on that. But I do want to talk a little bit about some basic care strategies. So just to talk a little bit about post-op care requires you have a little bit of understanding about some pre-frenotomy basics. I really love that this crowd has a good understanding of anatomy and oral anatomy because I really see both overdiagnosis and underdiagnosis of ties all in the same community. So I really like people to understand not every oral restriction, breastfeeding issue, or suck issue is a tie. So that's really important for me to get out there. Some other issues that may coincide with a tie or may masquerade as a tie might be structural, oral motor, neurologic or sensory issues, digestive issues, a maternal milk supply issue, respiratory concern, and all of these things can coincide with and complicate it. So that's why we don't want to just say, oh, it's a tie, it's going to all get better once we treat this. There's often a lot of factors going on. So I'm going to kind of skip through this. Anybody can get these slides from me afterwards if you're interested. But these are just some common complaints pre-frenotomy that babies and moms might experience. I'm just going to scroll through that one. Okay. Again, we're not going to talk about assessment, but I would encourage any of you that are working with babies on the post-op side to start to get a handle on pre-assessment, and that might be through other workshops and certainly learning to use Allison's tool, the Hazel Baker assessment tool for lingual frenulum function, and I know she teaches on that, and also understanding what is and what isn't a tie. I just put these slides up here for a few points of reference. You know, this is an obvious tie, and this baby down here was referred to me because they thought he had a tie, but to us body workers, it's probably apparent he has many other structural issues going on that aren't a tie at all. Okay. Just appreciate the oral structures and really look and understand how the innervation, the fascial tissue, the musculature, and we're talking about birth and how many birth issues can really pull things out of whack that require body work pre and post frenotomy. Okay. So as you're doing your work, the importance of oral work pre-frenotomy is multifactorial. So one, it can help unwind neuromuscular impingements to really set the oral tissues up for optimal release, kind of get everything in a good spot. It gets baby used to having something in their mouth, gets them used to safe intraoral touch. And I think that it really facilitates exactly what Michelle tells us about, that healthy nervous system response when babies are used to the work prior to going in for a treatment. In terms of treatment, I think that all of us come from different communities, so you may have treating providers in your community, you may not. Some people that do this work are ear, nose, throat doctors, pediatricians, naturopathic physicians, anybody that can do minor surgery, a dentist, anybody that can do minor surgery does this. So if you don't know who in your community is doing treatment, start to network and collaborate and find out who that person is. Because I think that it's important if you see a baby pre or post-op, you should go witness. You should witness a treatment. You should see who the treating provider is in town. See what that experience is like for a baby, because that baseline of seeing what a baby and a family goes through will help you do your work better afterwards, kind of knowing what they've been through. This is just an example of scissor release versus a laser release, because I know not everybody in here has seen what the procedure looks like, so I want to just for you to have an understanding of what that looks like. Okay, so here's where we want to have our focus today, is aftercare. So we're assuming that it was a needed surgery, it was done well by somebody who does this a lot, so we're going to just assume that it was done well and it was done by somebody who knows what they're doing. Let's talk a little bit about post-procedure pain relief for these neonates, wound care and wound healing, and then some of the aftercare ideas that are, like I said, in their infancy, and ongoing support for the family. Okay, so the big question that I usually get asked by families is, will it hurt? Will the baby experience pain? And so I really like to give families clear anticipatory guidance on what their baby may or may not go through. I think as we saw in a lot of the talks during this conference, that state regulation piece is really critical. I like to assess each baby and kind of say, wow, I think the baby's going to handle it this way or that way. Not necessarily out loud to the family, but if they're a high-strung guy or if they're just kind of mellow, go with the flow kind of a baby, they might react to the procedure differently, and I might really give that family some different anticipatory guidance on what to expect. And certainly the age of the baby, the older they are, the different reactions might come about. Okay. And a lot of times with some of these babies, the way they've been compensating to feed will kind of be stripped away. It's kind of like an arm coming out of a cast. It's freed up, but it's still really weak. So I usually give families some guidance around, what their baby may do after the procedure. Okay. So talking about pain relief for a moment, I work with a wide variety of families. Some are really into conventional care modalities, some are into holistic care modalities. So I like to give families options so that they can choose what they feel comfortable with. I will note that I am a big fan of treating providers using pain relief during the procedure, so actually numbing up the frenulum. I know there's some controversy around that, but I see the difference. I think the babies who get the frenulum numbed up during the treatment do better afterwards, and that's just what I see in my population. Okay, so some conventional methods that babies might use either right before or as needed afterwards would be Tylenol, acetaminophen. Of course, it's hard on the liver, so we just want to use it judiciously. Ibuprofen, it's a hit or miss with kiddos under 6 months, and the treating provider can kind of give guidance around that. For older kids, it does have a more anti-inflammatory effect than acetaminophen. Some people are using ice. I haven't met a baby that really loves an ice chip in their mouth, but it is vasoconstrictive and Some people, I haven't seen it in use in my area, use some oral sucrose, like the little sweeties. You could dip a binky or finger in it. And there's some clinical evidence around that being useful. I don't see it in practice here for frenotomies. I will say that any of those old school like Oragel, numbing gels with benzocaine are really contraindicated, especially for a pediatric population under 2 because of the risk of a metahemoglobinemia. Okay. Luckily, a lot of families I work with are into using holistic remedies, and I find they work beautifully. I do have blends of homeopathics that a lot of families are willing to use prior, during, and after, and I find them very effective. Some families want to incorporate some rescue remedy or some flower essences for the whole family. For older kids, I'll sometimes incorporate herbal options, just depending on what the family wants to utilize. And then really don't underestimate the pain relief that's in breast milk itself. There really are analgesic properties in breast milk. And things like co-bathing and skin-to-skin, and really just having some downtime can be also soothing pain relief for these kiddos. And a lot of people want to know, like, well, how long will the baby experience discomfort? And again, I say it's really baby to baby. So I have some babies who they get the procedure done, they're happy as clams, they'll sleep through the thing, then they'll go nurse and they'll be like it never happened. And then some babies who really are triggered, and I'm sure this has a lot to do with their state regulation, probably their nerve myelination. Every baby is so different. So I really let parents know, based on what I know about their baby, how I think they might react and what to prepare for. I am a big fan of pain relief as needed, whether it's conventional or holistic, because the research is really pointing to long-term effects for babies who experience pain without relief, even possible neurological issues later, and how they develop a reaction to pain. And I think it's interesting, you know, we do see a lot of moms who maybe have a sore nipple or whatnot going on, that it seems to not be in relation to what's going on, like their sense of pain is so much more heightened. And I have to wonder oftentimes, you know, does it go back to maybe their experience of childhood pain and how they relate to pain? Okay, good. So before we'll save Q&A for the end. All right, so wound care, I want to talk a little bit about how oral wounds heal. For those of you who work with babies after, do you find that the parents feel like they're doing baby torture when they do aftercare? Okay, that's not okay. So it is good to have a baseline of how wounds heal, just to understand why some aftercare is needed, because the mouth wants to heal so darn fast. And to be able to let a family know what that wound might look like, what the quality of the tissue healing might look like as it goes through stages. All right, so we'll talk about the stages of healing. Again, I'm going to go through those kind of quick so we can get to the fun stuff. And there are some quote-unquote gory slides in here, so if you're squeamish with blood, I'm going to preface that. Okay, so the first stage of wound healing is it's just the blood clot formation. So it's the tissue has been incised or excised or vaporized with a laser, and the blood clotting happens almost immediately. It happens very quickly in the mouth, and I'd say out of thousands of babies, maybe 2 or 3 that I've worked with have been bleeders that have needed a little bit more to stop the bleeding. It usually happens very quickly. The next stage of the wound healing is the inflammatory phase, and inflammation in wound healing is both positive and negative. Some inflammation helps do its job and helps that wound start to heal. Too much inflammation then can lead to disruption of how the collagen fibers want to form. Okay. Something interesting about oral wound healing that I've read is that there's a superior healing quality of mouth healing it's akin to fetal scarring. So a fetus up to the second trimester, they won't scar if they're wounded. Their tissue just heals superiorly. And they say that the mouth tissue is similar to that. And I think from an evolutionary standpoint, that makes sense, right? Like if we can't eat, we won't survive. So if our mouth gets hurt, we really need that to heal quickly. And I think that's probably one of those factors. All right. When inflammation is increased, more scarring and collagen fibers lay down. And I think this is interesting because our babies and moms that are super stressed out, maybe cortisol is super high, I think these are the families where we do see there is more scarring, reattachment that happens when they're in just a state of fight or flight the whole time. Keloids in oral healing are rare, and keloids are, the scars that kind of just keep on growing and building upon themselves. They're rare in oral healing, but they can happen. And interleukin-6 is a big factor of this. So again, think of the families or the babies who are really in always a heightened state of stress and how their wounds might heal differently, which is why baby torture is not the way to go after procedure's done. Okay, so after the hemostasis and the inflammation phase, then there is the reepithelialization and the granular tissue formation. And this starts quick. Within 24 hours, this wound wants to heal and the cells want to start coming in from side to side, meeting each other. That's like their full-time job, is that it wants to heal itself up. Okay. Various things stimulate this process. And at the same time that the granulation is happening, the reepithelialization is occurring too, and that provides scaffolding for connective tissue to regenerate. And the frenulum is connective tissue. So it wants to start healing, it wants to start healing side to side, but also building up from the ground up. So after that process starting to occur, the next phase is that the remodeling phase starts to happen. So it kind of wants to heal itself back up, get back in alignment. Collagen fibrils start to assemble and they align with the perpendicular wound edges. And contraction of the wound, anywhere from about 3 to 5 days post-op, they say, with some oral wounds. I think that may be true for most, but for some I see it take different time frames, sooner or later. The interesting thing about this process is it's both slow and fast. So it wants to happen quickly, but the resulting tissue is not necessarily as strong as it needs to be. And I think that's why when we feel the quality of tissue healing 1-2 weeks post-op, it's often nice, soft, squishy, because I think it's not as strong yet. Okay, so we feel like, wow, reattachment hasn't happened, but I think that's still very weak tissue. And then oftentimes at week 3-4, we go, oh, how did it get firm in there again? And I think that's actually the wound trying to strengthen itself, not always that it's reattached or scarred, but it's just that tissue feels differently to us. Okay. Some interesting points about oral mucosa. It's actually healed and bathed in flora-rich saliva. So we have to think of the implications when maybe moms and babies have poor flora, poor gut flora, how that might impact their oral healing as well. And another interesting thing about the quality of the cellular healing is that as that wound is healing, the local pericellular microenvironment established during remodeling determines the phenotype and function of the resident cells and may be the key to preventing pathological scarring. So as this wound is healing, it's actually starting to create its own story of how that's going to be set up. So I think that's fascinating. And the wound healing is impacted by stress. This researcher had, it was a dental school, he had students that were going to study for an exam, and some students were going to go on vacation. They all had like a punch biopsy of some soft palate tissue. And the students who had to study for the exam while their wound was healing, their wound healed so much more slowly than the students who got to go on vacation. Their wound healed up so nice. So again, as we're working with families, think how can we reduce stress to help their healing? Okay. And nutritional factors. I mean, gosh, how many people are deficient in so many of these things and how that might impact wound healing. And a lot of the baby's zinc is really from maternal zinc, and if mom is low, that's actually something that baby will be low in too. So again, thinking about how we can set these families up for success is often a nutrient issue. Okay. So to summarize some of the wound healing information before we talk about the aftercare, just remember the oral wounds do begin to heal fast. The cells start to migrate towards each other quickly, and inflammation, stress, poor flora, or nutritional status can impact that healing process. I won't go too far into it today, but we're learning more about genetic and epigenetic factors that might create more tongue-tied. Some people say that's happening, some people say it isn't. But I also think we should think about how is that impacting healing. Okay. And I think that reducing inflammation and doing aftercare of the site in a gentle way, but meaningful way, can maybe prevent some of that tissue from reattaching or scarring down. And there is no research on pediatric oral wound massage, so don't even look for it, or let me know if you find anything. But there is some information around surgical scars treated with massage afterwards, and that the quality of the healing and the appearance is better. There's just nothing that I have found for oral wound healing. So like I said, kind of what we're doing in the mouth post-op is kind of like the wild, wild west. Like we think it's a good idea, but we're still learning as we go. Okay. So there are some babies that we may work with that they really heal in ways that are probably suboptimal. I often try to look at the family prior to treatment to see, boy, do dad or mom have keloids? You know, just where they get a little scratch, seem to be scarred in a disproportional way, and really kind of see like how might that baby heal. Some people are playing around with the idea of topical calendula or food-grade aloe vera on the incision sites, and there is some research in the dental, in the body of dental knowledge that shows that these can be useful options. Okay. There's also some information about essential fatty acids playing a role in oral wound healing. So we kind of think, you know, setting moms up maybe with their probiotics and good essential fatty acids preconception, prenatally, and then afterwards, and maybe even directly for older babies, might be a way to help. Okay. What parents should expect afterwards, in my opinion, is about 1 better feed per day after treatment. I really like to give parents clear guidance that this is not usually going to be a quick fix, because usually the babies I see have other issues at play. But for some families feel like they get the treatment and then the baby latches and they feel like, oh my gosh, that was a miracle, it feels better right away. And some families feel that one time and then they feel, oh, well, afterwards it wasn't so great. So I like to set families up that, you know, expect 1 better feed. That might mean that your baby transfers a little more efficiently, or that your nipple's a little less sore. So I like to let them know those baby steps of progress are gonna happen. All right, and hopefully they're working with, you know, the village of people, body workers, lactation consultants, but really their plan should continue to evolve as the baby's needs evolve. I like to let parents know about what normal wound healing looks like, and we'll look at a couple pictures on that, because parents might really be freaked out about what that incision site looks like afterwards. So it's good to let them know what they might see. All right, so here's just a few snapshots of a mouth. Let's see, it looks like this was 1 week out. But you can see here this yellow, and it's not oozing or anything, it really is sort of a mouth scab. That's just how the mouth heals itself. So I've seen green, yellow, orange, different colors can happen, and parents can get a little worried, like, is this infection? But it's good to let them know that it's normal. Corinne?
Are those laser or scissor?
These were both laser, about 1 week post-op. And then, you know, some just kind of look like this kind of white patch here. So that's normal. So if you see that, that's kind of a normal healing. Some things that just to know if you are treating an infant or working in their mouth that wouldn't be normal would be really extreme inflammation or redness. If it really looks angry and bothered, you might want to have that checked out by the treating provider. Prolonged bleeding or oozing, you know, really the kiddos I see that bleeding is really done almost before they leave the office, and maybe if we're in there, like, it'll ooze a little bit, but really if the bleeding continues, should get that checked out. And really if the baby is inconsolable, I don't feel that it's okay if a baby really is crying for a prolonged period, or every time they go to feed they're refusing. That's a kiddo that's in pain, and that needs to be addressed. I have had babies come in a week post-op, and then the parents say, oh, they're just crying all the time, and they're in pain. Like, let's give the kids some Tylenol, and they're fine. So babies really do, not all babies, but some babies really are triggered for a while after. I want to look at some after pictures just so you get a baseline of what you might see if you're working with a baby. This is just day 1, so it's sort of fresh. A lot of the pictures I'll show are by a laser release. I'll show some scissors too, because I realize not everybody here has a provider in their area that uses a little laser, and the wounds can actually look different, scissor versus laser. So that's a pretty normal release, and you can see sort of that diamond shape, so the tongue was tethered all the way from almost the tip to there for this kid. Okay, this is a scissor release. This was a little while ago, so actually I wouldn't be okay with the way this looks now, but this was back then. So you can see this is one day out. You can see that tissue is already wanting to start to do that scaffolding process of building back on itself so quickly. Okay, and this is a bit of tissue. It's actually excised, not just incised, so a little bit was removed. Okay. So you can see the difference. Let's see, scissor, laser. Laser looks a little cleaner. There's actually a little bit of an anti-inflammatory effect that the laser produces as well. So I think it just looks a little bit cleaner. This is still just one day, just like the other baby. Here's 3 days. You can see how that tissue is really starting to heal up on itself. I think you can see that one a little bit there. And that granulation is already starting to occur. But it's still soft, it's supple. If you were to wipe your finger over it, it would just be really smooth and soft. Here's about a week out. Okay. About 2.5 weeks out. 3 weeks out. You can see the release has maintained. And with the aftercare, you know, the site stayed nice and soft and squishy with no scarring. Okay, and here's just a difference of appearance that you may see just depending on where you work. This to me is just not acceptable. That's really messy. But you can see there's a bulk of tissue that's left on the alveolar ridge, but it's only been incised. So a frenectomy is just an incision, so nothing was removed. It was just incised. Here is frenectomy. So ectomy, it was excised, a little chunk. All this stuff was snipped out. And then here is the same type of procedure, but done with a laser. So you can see it just hugs the gum ridge. Janine?
Yeah, I have a question, laser versus scissor, as far as parents in the room. I'm curious what your opinion is about this with laser.
If parents can be present, it's really not, it's more of a state law thing with laser. So here in Oregon, for example, anybody that's in the treating room, you have to have laser safety goggles. A little baby wears goggles. So it's a laser safety issue, and it's just too much to have parents in the room there. So it's not like, oh, we don't want the parents to see it.
Right.
It's just it's just the law. For scissor, absolutely, we'll do that right there with the parents in the room. You know, if they want to hold the baby, if they want to step out, whatever their level of comfort is. So even though we have the option here, if parents are adamant that they want to stay in the room, then they have to choose the scissor procedure. And it might be different in other.
As far as I know, laser can be quicker and better and more healing, but
Yeah.
the parents can't be there
You know,
for the baby.
It's interesting. I actually, I haven't met too many parents that actually like to be there with the baby. Like I mean, for some parents, they absolutely want to be there, but a lot of parents just are like, oh yeah, just do it over, bring it back to me. You know, I guess it really depends on the family dynamics. So, and for the baby too, I mean, I think that they're right back in mom's, like in a minute or two. Like it's very quick. The separation's not long, but we can talk more about that. Yeah, Allison.
Can I just comment that laser does not necessarily do quicker and better wound healing?
Okay.
It just doesn't. You
Yeah.
have to get off of this
Yeah.
thing that laser is superior to scissors because it's not.
Yeah, and I want to clarify that too. I don't think it's a superior tool. I'm showing you the difference of what it might look like afterwards. And again, that's going to depend on your treating provider. I think it's more about the hands of the treating provider. I've seen great scissor releases, I've seen great laser releases, and I've seen crappy scissor and laser releases. So I think it's more that it's a cutting tool. It's a tool. I do feel like the quality of healing I've seen in both does have some variance, but yeah, I would agree. It's more of the treating provider's experience. Okay. And it also is going to depend on where you're at. Not everybody has access to laser. Again, just one other quick picture, a little kiddo who was developing a diastema, and you can see that labial frenum was starting to create a gap here, and their dentist suggested doing it, so that's just showing an older kid's mouth. Okay. Reattachment starts to form when the healing tissue starts to heal down on itself and form a scar. You can kind of see here, this is a bad picture, but this bit of frenulum was already incised, but it had started to grow back and create an issue for the family. I just want to look here. And I think you can kind of see the difference. These are both, I think they're 2 weeks out. about 3 weeks post-treatment, I think. And you can see both of them are 3 weeks post-treatment, how one child has healed compared to the other. And I'm sure there's lots of factors involved there. It's not just do the parents do good aftercare or not. There's many factors that play in how people heal differently. All right, so some of the goals for our aftercare are being able to assess that baby's strength or weakness or strengths or weaknesses. Check out the incision sites, make sure they're not in pain. I'm a firm believer in no baby torture. Lots of parents come to me saying, oh, my kid hates the stretches, they hate the exercises. I'm not okay with that. This really has to be a connection activity because these families are already often stressed out. We'll talk a little bit about positions for holding baby while you're working with them. Okay. And then really helping parents understand this can be a connection activity versus something that's stressful. Okay. So a few things that you can check out, and there are books on this, there are many more resources authored on just some basics, but things that we're going to look for pre and post would be how that tongue extends, how it elevates, how it lateralizes, the tongue cupping, the overall tone and strength. You know, is there a lot of cheek weakness? Is there some tongue strength issues? You can often use the same assessment tools pre and post to sort of compare how things have improved. Okay. How are the incision sites looking? Is there any ongoing inflammation that doesn't seem normal, oozing or bleeding? Okay, any reattachment that you note is starting to form. And I also want to say just with reattachment, it doesn't have to be perfect if function and mobility are fine. I don't care if there's a little bit of healing that looks like reattachment. I don't feel that that's a negative thing. You know, frenulum isn't evil. You know, it just doesn't impact mobility or functionality. And so a little bit of reattachment to me isn't an issue either if our goal has been met in optimizing function. Okay. In my opinion, there's no one right way to hold a baby. You know, some providers firmly believe the baby has to be upside down, you have to be over their head, or you have to do it this way or that way. And I really like it to be comfortable for mom and baby. Okay. So here's just a few positions. So some people are taught you have to be over the baby, leaning in their mouth. I don't feel comfortable doing it that way because I like to look at the baby, I like to talk to the baby. For older babies, as Michelle was saying, some kids who just check out and it's like too much face-to-face contact. Sometimes facing them outwards, walking with them away from you but staying connected can be great, or for older babies who need that distraction. But primarily I'll have either myself or the parents sit with the baby, looking at them, maybe a pillow on their lap for comfort. Okay. All right. Mm-hmm. Make it playful. We're talking all about polyvagal. I mean, this is it. We want to make the infant learn that our touch is safe. They can trust us. Every time we come near their mouth, we're not going to hurt them. Going through the procedure if it's needed is one thing, but after that, it really should be about rebuilding that connection. All right. Some people ask me, well, how often do you have parents work in the mouth? And I usually say because I make it fun and playful, it usually just becomes something they do. So I really stress, like, let's try to do it a little bit every feed, or maybe once the mom switches sides, or before a bottle burp, or however they're feeding. And usually the baby enjoys it so much, it just becomes their go-to little connection activity anyhow. I don't make them wake up in the middle of the night and do it, you know, like really, they need to sleep. But I like to do the fun stuff first, and then massage into the incision sites. I like to do it when the baby's quiet alert, so that they'll follow and they'll mimic and they'll work with us. I don't want to just wait till they're crying to just get in there and dig into the wound. I want to make it playful and gentle. And there's also times when it's okay to just get in and out quickly. I'll show you just a few examples of some work with babies so you get to see that it's fast. Just a disclaimer for some of the videos you'll see, which I have permission to show all of them. A couple of them they're repetitive, so I really wanted to just show some basics that all parents or all providers can really do safely. We're not going to talk about specific oral motor exercises or specific cranial techniques. I'm really showing just a basic rundown of, hey, here's a few things you can do post-frenotomy that will be simple, you can teach families, and that they can do on their own pretty easily. All the more specific work will hopefully be done with experienced providers. Okay. And also babies love repetition. What I usually find is that when we have a little set of exercises we go through, the babies look forward to it. By the time you're doing a few things, they're like, yeah, I know what's coming, and it really starts to be a game. All right, I'm just gonna go through a sample care routine that you're gonna mix up depending on what that baby needs. So when you see the video, I'm just gonna talk you through now what you're seeing so that you can see it in action. A lot of babies I see have jaw tension because they've been chomping and compensating because they haven't had good lingual range of motion. So oftentimes they have a very tight jaw. Many of them have been bottle fed or finger fed or whatever reason why they're keeping their mouth very narrow and they're not opening wide. So oftentimes the first little exercise I do is really just conditioning them so that when they feel a touch on their philtrum, like nipple here, that their next step is to open wide. And so my silly sound, I think I got this from Kathy Watson, is just to go beep, bop, boop, bip, and do a little jaw tug. And what they start to hear with these repetitions is that a touch here means open wide. And I swear if you do this a few rounds, by the time you're here with your finger and nipple, a kid is gaping. And I'll meet kids in a grocery store, the kid will be one, and the mom's like, we still do beep, bop, boop, bip. They love it. Like, great. And then a next thing that's very simple, simple to us, but when you're telling parents these things, like, oh, it's a great idea. But it's just some jaw massage. It's just kind of setting up that release to open wider because there's often so much clenching here. Gum rub for lateralization seems obvious to us, just tracing the gum line so that tongue can reflexively lateralize. And when you see these kids, you'll see the ones that are struggling, the tongue is humping on the other, their tip is not following, they're just trying to hump the body of the tongue up. It's a reflex for them to lateralize. So when they can't do it well, something's up. And it's not always a frenulum issue, but the lateralization technique can help. Wipers on the palate. Again, I sing a lot to the babies. We do wipers on the palate, go swish, swish, swish. And we sing in the mouth. And you can teach parents gentle cranial techniques. You can teach them, hey, you feel that bony ridge there? Bring your energy to each side and kind of ask this side to release and that side to release. So there's a lot we can ask parents to do so they're not dependent on coming to us every other day. Often kids who have not had their tongue putting pressure on their palate, in utero and beyond, they have that hypersensitive gag. They just haven't had much up there rubbing. And so just kind of bringing some gentle touch and letting parents make it a sing-songy thing can be useful for both spreading the palate and helping desensitize that hypersensitive gag. The kids where you can't even get your finger, in their mouth before they're choking. Tug-of-war, obvious, you can do this with your finger if the baby does use a pacifier with a pacifier. If you're doing some finger feeding therapy, you can do it at that time. You can do a little tug-of-war motion. You can put some downward pressure. Sometimes kids need some reverse pressure to get peristalsis going correctly. Those things can be individualized, but kind of working with the tongue a little bit. After that, I'll usually have families lift the lip like peekaboo, and with a rolling pin style, kind of work over that tissue gently. And same thing, lift the tongue and rub over that incision site nicely. You can teach them how to do some gentle but firm pressure, but then also some nice cranial touch. You can really show parents, even in their own mouths with their permission, hey, here's what this feels like. Do you feel the quality of my pressure? Okay, so again, sample little care routine that families could do afterwards. Can be individualized for each baby while they're receiving the different care modalities and body work they need. But this is simple. Families remember beep, bop, boop, bip, and we're going to do a jaw massage and a gum rub and a little tug-of-war and wipers on the palate and rub, and you're in and out. This doesn't have to be a torture session. It's quick and babies like it. So here's just a little guy. Let's see, Wesley, doing this work with, can you guys hear? Seems like there's a little bit of a lag. Sorry, guys.
Can you come over here? Yeah, lateralization is a little more complicated for you, but you're doing good. What about over here? Good. Better.
Should I stop it and restart it?
Good. How's your lip healing?
can hear the playful sounds.
It's the diamond shape. Rub, rub, rub. Nice, supple. That healing extra looks good. Rub, 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 and toss.
Sorry about that.
And the wipers on the pad. Swoosh, swoosh, swoosh. Wipers on the pad. Swoosh, swoosh, swoosh. On through. Now. Good. You got it. Let's ask you a couple more. Sensitize. It's your turn. Nice little more broad fitting of the tongue spread. That was great. Good. Thank you, Leslie. You're a great participant. Thank you.
Oh, sorry the quality was so poor. Well, sorry the quality was so choppy, then you don't really get to see the fluid movements. But you can see the babies really do get engaged with this work, and it doesn't have to be a cookie cutter set of exercises per se, but I really do like to have parents do something that they can do on a daily basis with their baby. We're gonna
How many times a day?
I just have them kind of do it every feed so that it becomes habitual. You know, when you tell a parent to do it 4 times a day or 6 times a day, then they'll be like, did we do it 4 times? I can't remember. So just try to tell them, like, do it every feed or every time your baby's quiet alert, or put a little sticky note above your diaper area saying, you know, mouth work if your baby's happy spot is on their, you know, changing table. So just try to do something that'd be habitual for them. So ideally like 4 to 6 times a day, but again, like this.
But not including middle of the night.
No, I don't. I mean, some people say that, but I'm just like, yeah, very few reasons to wake a sleeping baby. Or, well, if it's the middle of the night and like they're already up and they want to just rub a finger in there, but I wouldn't wake them to do it. Some people would disagree. Let's hope Stewart's video plays a little bit more smoothly.
I'm just going to show you the sequence of that work that I
Oh, maybe it won't.
and we'll kind of assess what I still need some work. Yeah, you've been practicing that already. That was pretty loose. I can see you guys have been working on that one. Lean right in. Can you try to come over here? Good.
So even when the baby's a little worried looking, you keep going?
I don't know that he looks worried to me. He is also passing gas. You just can't see that. I think he's engaged and not worried.
So a little cheek dimpling here.
Yeah.
Yeah. Much stronger with the little cheeks approach. This is actually.
These kids often have really poor cheek tone.
If you're doing a little bit of exercise, you kind of do a tug of war.
Yeah.
That if you feel like it's just flopping around like that, that you just give him just very gentle. He doesn't need a lot. And a little tug of war. Same thing if he's trying to use the pinky. Let's assess your cheek tone. You ready, mister? Let's see. 3, 4, 5, 6, 7, 8, 9, 10. So I can do up to 10 pulses and he's still
Yeah,
not.
he's not contracting his cheek muscles, so she should reflexively after just a few pulses.
Let me try this cheek. 1, 2, 3, 4, 5, 6, 7, 8.
That cheek is stronger.
So one of the little exercises you can do very, very gentle. The cheek muscles are just delicate. They don't need a lot. 1, okay, and then do about 3. So just these little teeny pulses.
Pulsing into
Yeah, into the cheek muscle. It's a reflex because we use a little smile muscle to contract. So I would do upwards of 10, and if he hasn't contracted by then stop. We'll come back to it later. But if you start to feel like every time you do it on around 1, 2, 3 that he smiles and he uses that muscle, then you'll feel like that's strengthening. And that's what you'll start to feel the rest of it, recruit those muscles more and stop chomping as much. Let's see what else is going on. So many mysteries in your mouth. Okay, a peek-a-roo. So that white gray, that's not infection, that's just how that little tissue
And you'll see sometimes I'll do a distraction noise, I'll brrr, or make some little sing-song to take their mind off of the discomfort momentarily.
And then we'll do the tongue will be all over.
Because you're right, Nikki, I won't push through if they're tense. He was just 1 day out too, so.
So I'm just going to go with the one side of my finger here and just going to rub all over the wound. And I'm going to push up because I'm a little bit of stretch. You see the line.
And then stop. Yeah.
Rub it all the way across. I know, buddy. Let's give you a little bit of relief there. I'm so sorry that was tender. It's still a little bad this way, but it's definitely. Okay. You guys have done a nice job keeping that.
Yeah. Helga?
What's the bandage position? Do you have them on a wedge or?
Up, just a pillow on my lap. I put a pillow on my lap, just sitting on a sofa. Yeah. What was I going to say about that baby? Oh, a lot of times they do have some cheek tone issues because they've been compensating with the mandible or just different issues can create cheek tone problems for these kids. Was I going to say something else about this video? It'll come back to me, I'm sure. Okay. All right. I was going to say something about pain. Oh, I'll do a distraction sound or something, but for the purpose of showing parents, sometimes I'll linger in there a little bit, but I would tell them not to necessarily spend so much time there. Oh, I know what I was going to say. I really give parents some ideas around working with the tissue. I'll tell them things like, pretend your finger is a warm knife melting into butter. Like I want to give them some sensory qualities where they can kind of just feel, ask that tissue to just melt for you and soften. So I like to give parents ideas like that so they're not just in there, rubbing around, but just giving them some ideas of, how you want to ask that tissue to soften up. Okay. Again, just showing different examples of either the tug of war or the gum lateralization. The jaw massage, chin tug, the beep, bop, boop, bip to help conditioning for opening wide. Okay. Again, the peekaboo of the lip and then rubbing over that area with your finger to help that wound heal in a nice elongated way. And same thing underneath the tongue, pressing up, rubbing over there like a rolling pin. And not just the wound site, but really the whole floor of the mouth, because it's again the sides where the wound's contracting and the cells are working their way towards each other. We want them to heal nice and elongated up and down, so we don't want this motion. Okay. Let's see. Due to time, I'm going to skip through this one. Is there anything special about this? Let's see. Skip through that one. Okay, so I'm just going to skip through a few more things to the end since we're cutting it close with time. In terms of breastfeeding and positioning stability afterwards, again, hopefully they're working with somebody who can really help them make this optimal. Sometimes they need some more sublingual stability or cheek stability, helping them get into a better state. Just a few positioning, options that often work with these babies. Instead of them being, flat on their back on a boppy or something with more tongue retraction, anything we can do to get them a little bit more prone and facilitate tongue extension is going to be a little bit easier for some of these guys. Sometimes they need a little support sublingually or a little cheek support. This is different. We're not talking about old school in the NICU, hold their cheeks so we can force feed them. It's nothing like that. This is really just gentle support. We're just giving them a little extra stability, and I often find it makes a big difference. This guy, without this, he'd just smack and click and get in tons of air and be very inefficient. And with just a few grams of pressure, he then could get into a good steady groove. And I think I have a video of him. We'll see if it cues up. Again, this is just prepping a little one who you couldn't look at her without her gagging. And she had some other issues going on, so I'm sure you'll see them in the video that we're working through and her care team was working through. This is just really encouraging parents to do some oral work with their kids at home.
Can you greet my finger? Good. So sometimes just sticking, sticking happy. We're just kind of putting it on the gum line so she wants to lick and taste. Yeah. And then mimicking mom's tongue. And when she gets close to sticking her tongue out, touching the tip to kind of reward her. Yeah. Good. Okay. Can you tell me all about it? Yeah. Will you invite my finger in a little bit? Good. While you look at mom, that's great. So you can do this while maybe one person distracts her and the other person gets in there like this. So we're just kind of putting a little bit of pressure on the middle of her tongue and remembering that cheek compression. That kind of helps her cup around my finger. But she's so engaged in your face that she's kind of reflexively doing something without even thinking about it.
Which was good for her because she was a smacker, not a sucker. She really didn't cup
Oh, beautiful, Kira.
really well at all.
And you know how we mentioned doing some of this preparatory oral work right before she goes onto the breast will kind of be a good warm-up before the marathon. Good. This is actually the best she's done yet today. And maintaining cupping around the finger. Good. Good. We want good extension and cupping. And less smacking. Good.
So
The quality of her second
doing some of this work prior to feeding really helped her regulate and do better work right before when she was feeding. So some of these exercises can be done right before feedings. Okay. She had some other health issues and she was working with a great team, but the oral work really helped her transition from not being able to take a bottle. She would take the breast, she would accept that. She was pretty inefficient though, and just clicked and smacked. You know, good thing actually this mom had a quick flow, otherwise the baby probably wouldn't have gotten fed. But she had some other issues, but doing the prep work for her to help before the feed got her in the right frame of mind and got her mouth doing some good things. I think we have time. I'll show this real quick and then we'll scale through to the end. This is again just an example of that kiddo who just needed a little stability while feeding. And not forever, just short term. So you can see the nice rhythmic drinking, suck, suck, swallow, suck, swallow. So if she lets go, he just stops.
Are you bracing under the chin?
A little bit, yeah. And once she goes back to just a little stability, he picks back up. This is choppy. Okay, well, you get the idea. I'm going to scroll through since the quality is not that good. So some of these kids need a little support in many ways to get their feeding successful. And these are just a few snapshots, by no means a be-all, end-all to this work. So in terms of the aftercare, I should say post, you're going to let your heart and hands lead the way in terms of what body work the baby needs. Things like asking the tissue to melt and release and letting parents know the verbiage as well can be useful. I'll even, with parents' permission, show them in their own mouths the quality of touch that I'm looking for. And I do encourage that families make it playful and they really focus on it being a connective activity. So since we're out of time, I guess I can maybe do 5 minutes of Q&A. 10 minutes of Q&A? Okay. Great.
Based on when you started.
Oh, perfect. Okay. So again, I just want to end this by saying a lot of this is really uncharted territory. Nobody knows exactly what is best post-frenotomy. We do know that the wound heals quickly, and I do think some gentle touch and working over the incision sites can help it from healing in a suboptimal way. That's just been my experience, but I really am a fan of making it a connective activity with families. So this was just meant to show you some sample ideas of that. Yes, Sadie?
So my question is that when you do the post-frenotomy exercises, do you increase the risk of the tissue being more inflamed because you are kind of sort of massaging it?
Sure.
Gentle?
Sure, I mean, I think that can exacerbate inflammation. There's that balance, though, of a little inflammation and the healing process is okay. Too much is not. And that's why, we don't want digging around in there. And I will also say, these don't get infected either. So, I mean, reasonably, clean hands, but it's not an area that really gets infected easily. It's just always keeping itself clean.
Is there any way for the moms to can we suggest to moms that they could use some breast milk on their fingers?
Sure. absolutely.
Just to, like,
I mean, the thing is, it's pretty usually goopy, and there's saliva, and babies are teething, and it's pretty wet in there already. But you're talking about just for like inflammatory purposes? Sure. I mean, I already usually assume their mouths are kind of bathed in breast milk all day long, but sure, they could use some on their finger. Yeah. Yeah, Beth?
What would be your tagline for a mom who has extremely painful nipples during breastfeeding and then they're contemplating doing this procedure? And then what would be your tagline of like when they could expect their nipples to feel less sensitive or painful?
Yeah. Thank you for bringing that up. There's so many factors with sore nipples. You know, the tongue tie might just be one of those factors. If we ascertain that there aren't, you know, a bunch of other issues going on, again, I look for that one better feed after. I really want parents to go in not thinking like, oh, this is going to be a miracle cure in day one. Everything's going to feel better. So I'd say, gosh, that might be one more comfortable feed a day, or maybe your toes will curl a little less that session. And some of these families are already doing a combination of some nipple rest with pumping or feeding away from the breast in some instances. So if there are no other issues at hand that are making her have sore nipples, which often there are, then I would say maybe like one better feed per day. And usually these moms do feel like, wow, that's better if it was just the tie.
So after 3 to 4 weeks, then it would be like 2 better feedings?
Oh, no,
Do they just
one a
want,
day.
like, one a day, but then,
Yeah.
but like till what? They want a blanket statement, like
Sure.
when am I going to feel like
I feel usually
was
that
worth
there's
it?
one more comfortable feed a day, and that first week or so out, they're feeling some significant changes, and that by 2 weeks out, there's usually more significant changes. And sometimes they need a balance of giving their nipples a rest if it's that bad. But you know, one better feed a day, you know, if the baby's eating 8 or 10 times, you know, a week or 2 is reasonable. Yeah. But if the baby has a lot of other compensatory behaviors or issues, if it was just the tie, that's one thing, but it's usually not just the tie. So it really depends on how we're unwinding the other issues at hand, how quickly we're able to do that. Nikki? Oh, sorry. Okay.
So the mother is really sore and she's involved keeping her well. Are you teaching pacing? How do you have any special alteration of bottle feeding technique to help this tongue and this baby or this lip?
Yeah, that's a great question. I work with bottles all the time, so I'm picky about which kind of bottle, the flow rate, the teat shape, and using a tool that's going to support better sucking skills, whatever it is. So yeah, we'll be picky about the bottle. Pacing. So I'll just clarify pacing. I don't subscribe to the camp of 1, 2, 3, stop. 1, 2, 3, stop. I want to pace with the baby's natural suck burst pattern. So if they're drinking happily, we're going to go with that. When they pause, we'll pause. So I don't like artificial pacing. I want that baby to have their natural suck burst pattern. Does that answer that?
And then how do you pick bottle nipple?
I have a few go-to favorites, and we could talk more about that if you'd like. And I'm really picky. I want to match, you know, a teat, a base that the baby can actually cup around. Most often, those wide base, like a breast bottles, the baby can never open and cup. So a lot of times, I use really just old-fashioned, like an old-fashioned Dr. Brown's or a Playtex Ventair Nero or something where they can accommodate it and the flow rate's not going to overwhelm them. Every baby's a little different, so I'm probably the weird lactation consultant. I have a billion bottles and binkies and tools in my office for different babies I see. Yeah, Beth, you happy? Back there, Carol? I think it's about 5 minutes. No, we're on to what? My timekeeper. Oh, I think there's one back there, sorry.
So what you've been showing is what I was taught was an anterior tongue tie.
Uh-huh.
Do you do posterior tongue tie?
I actually don't like the term anterior or posterior because a tie is a tie is a tie. If there is restriction, I don't like to give it a name. Now it's true for the sake of dialogue and people who need words to describe what they're seeing. There are ties that are more anteriorly located, they attach closer to the tongue tip, and ties that are closer to the posterior tongue base. So some people still differentiate, that's an anterior tongue tie. That usually just means it's, you know, more visible to them. This work, in my opinion, would be for babies regardless of the type of tie, the classification of the tie.
So I'm seeing, well, just to clarify for myself, this posterior tongue tie that's
You're saying you're seeing that in your practice or in my pictures?
No,
Oh.
in practice.
Um,
I didn't see it in your picture.
Well,
so I'm asking.
I didn't want to make this presentation about assessment because I do feel like it's its whole own conference. But I will preface that by saying I think that a lot of deeper restriction, especially what you're seeing that bilateral, that there's often not a tie, or there's a tie but there's other issues. Sometimes we'll work in the mouth and that tie might pop up with more clarity. We'll say, oh, hello, there you are. But oftentimes I feel that that is more fascial restraint, neuromuscular impingements that are pulling the floor of the mouth in ways that look like a tie. Allison calls it a faux tie. So that's where we have to be careful, because I feel like a lot of these babies are getting cut and whoa, why didn't it help? Well, because that wasn't the issue. Yeah. So do we still have time or should I wrap it up? I have 2 minutes?
Melissa, I've seen like women in my practice, like it may take as much as like 3 weeks for them to get into a exclusive breastfeeding relationship with their baby. And so what I'm wondering is sometimes some of the moms, and these are the moms that come off of like a high stress birth, and then they move into the breastfeeding issues and then tongue tie, and they're amped up. And so what happens, then they get focused on the pumping schedule because their next great fear is my body's not going to work and my milk's going to dry up and I'm not going to have milk for my baby. And then they're doing the exercise and you just see this snowball, And I love that you said like, okay, one feed, one good feed, that feels better, that's perfect. But what do you say to moms about how often they need to put their baby to the breast? Because of what I'm hearing is, I'm afraid my baby's not going to gain weight, I'm pumping all the time, and I just don't have time to put the baby to the breast. And I'm like, whoa, we've lost it.
Well, I don't know where you live. I mean, I hope that you would have a good lactation consultant or someone they can be working with, because that is my whole job, is creating a plan that's sustainable for the family, that's realistic, that's not a cookie cutter, oh, nurse, and then pump and do this and do that. It really, hey, is this going to work for you? And we know like there's some basics, like we know we have to feed the baby, we know we have to protect mom's milk supply, and then we have to keep sorting through what's happening. But I think that is where like the role of a good lactation consultant comes in, is that, hey, how can we facilitate them coming from a place of stress to say, like, how can we move into a place where this is a little more manageable day by day? And I think I'm getting the cutoff sign by Carol. I'm going to have some cards and some flyers out front, and I'd be happy to talk more. Slave to my email, so feel free to shoot me a line if you're not local. And I thank you all for participating.